Welcome, everyone. Welcome to the Newborn Toolkit webinar on neonatal networks, what works to move faster together. Welcome. Please introduce yourself in the chat. Bienvenue. Please introduce yourself in the chat. My name is Dr. Mbozo Gracie Palo. I'm a clinical researcher and knowledge management co-lead of the Newborn Toolkit, and would love to welcome you to yet another Toolkit webinar, and happy Tuesday. Next slide, please. Welcome once again. Just a reminder on what the Newborn Toolkit aims to be. The Newborn Toolkit is a multi-country, multilingual learning platform for high-quality small and sick newborn care. In 2026, we had over 62,500 unique visitors from more than 200 countries and territories, and we aim to be a platform that brings communities together through our regular webinars such as this one. The Newborn Toolkit has over 1,000 tools in 15 languages, technical content in French, and linked communities of practice in English and French. And this platform exists to highlight that national targets for SDG 3.2 newborn survival cannot be met without small and sick newborn care. And as we know, in sub-Saharan Africa, we have 80% of the neonatal deaths globally. And we aim to highlight that and bring communities together to action forward ways to move faster together for small and sick newborn care. Next slide, please. Just to highlight, this webinar is being translated to French. And if there's any French speakers, would love you to listen to the webinar in French. This webinar is structured around the 10 core components of small and sick newborn care based on the WHO and UNICEF components. And the topic today is on neonatal networks, what works to move faster together. To join the Newborn Toolkit and to hear about webinars, news, and share tools or ideas, sign up to the Toolkit newsletter. And on the screen now, you have the QR code for the Toolkit newsletter in English, the Toolkit newsletter in French, and you can follow us on Blue Sky, Twitter, LinkedIn, and Facebook. Next slide, please. So the Newborn Toolkit is based around the WHO UNICEF health system building blocks, and we have had quite a number of past webinars on leadership and governance and leadership in neonatal care. And on the screen now, you see our past webinars on leadership, on the topic of leadership in neonatal care for 2025, 2024, and 2022. So this platform is a growing platform with a lot of information that can still be useful to different settings, and we all encourage you to look at our past webinars on this topic while we explore the new topic this year on neonatal networks. Next slide, please. And our upcoming webinars in July will be focusing on neonatal workforce equation, how many, how much, how fast, exploring the neonatal workforce and what is key to note as we explore staffing in newborn wards. And in the first week of August, on 4th August, we'll have a World Breastfeeding Week webinar and many more exciting webinars to come in 2026. And we encourage you all to join these webinars and share with your networks. Next slide, please. And now I'll hand over to my colleague, Lauren, to share a bit about the webinars in French. Over to you, Lauren.
Thanks, Mbozo. Donc, bonjour et bienvenue à tous nos participants parlant français. Si vous voulez écouter le webinaire en français, s'il vous plaît, cliquez sur le bouton de traduction affiché sur la barre de menu de Zoom pour accéder à la canal français. On a aussi quelques webinaires à venir en français le 21 juillet. Les questions des ressources humaines en néonatologie, combien, à quel coût, en combien de temps. Et le 4 août, semaine mondiale d'allaitement maternel. Donc, nous vous invitons à nous rejoindre pour ces webinaires. Next slide. And very excited to introduce our host today, Tasman Boda. So she is the founder and executive director of Premi Connect South Africa. She has a background as the parent representative for GLANCE, the Global Alliance for Newborn Care. And we're also very excited that she was our winner of the 2024 Newborn Toolkit essay contest, which focused on family-centered care. So we're very happy to have her back today as our wonderful host for this webinar. Without further ado, I will hand over to Tasman.
Thank you so much, Lauren, for having me. I am always excited to join one of the webinars for the Newborn Toolkit. And I think this is a very important conversation. And I'm so excited to see how multi-stakeholder engagement is coming to fruition. And I'm just going to share a little bit about what I think about leadership and governance. I never set out to start an NGO. That was never the plan. What I wanted was to give thanks to our NICU team and give back to the community and let them know they were not alone. Because when I was sitting next to my baby's incubator, I felt so alone and that no one understood what I was going through. And I didn't want other parents to have to feel that way. But I also wanted access to information because I was very afraid as to what my child's future would look like. This is when I approached those responsible for shaping national health policy. I entered that meeting feeling like just a mere mom who was looking for support. I left the room realizing that there was a big gap and that being a mom is in fact my superpower. That belief was deepened when I joined the Global Foundation of Newborn Care and then confirmed in a moment I will never forget. I was sitting in an international meeting, very quiet, feeling that familiar smallness, and the chairperson stopped the room, asked everyone to pause, turned to me and said, "Tasman, your input is valuable, and we really want to hear what you have to say." In a room full of qualified clinicians, a leader chose to create a space for a mother's voice. I think about that moment every day because it showed me what leadership in governance actually looks like. It's not just structures and accountability frameworks. It's whether the people most affected by decisions being made are included, are heard, and are trusted to lead. Premier Connect went from being a parent-led organization that provides emotional support to families affected by prematurity to ensuring that the decisions shaping the most vulnerable moments of families' lives are never made without us. I don't know about you guys, but it still brings chills to me being able to sit on platforms like this, giving parents a voice. But I think what is even more special is that everybody is now aware of how important each of our roles are in ensuring that small and sick newborns are catered for, and that they are looked after and that they are born healthy and that they can survive and thrive. So thank you, everybody. We're going to move on to our very first speaker today, which is the EWEN program report. And we have Dr. Gagan Gupta, who is the Unit Lead Maternal and Newborn Health for UNICEF, the co-chair for EWEN Country Implementation Group and Advocacy Group. I mean, he brings a wealth of knowledge to this discussion, and we are so excited to hear what you have to say, Dr. Gupta. Thank you so much for joining us.
Thank you so much, and thanks to all of you and Joy for inviting me for this webinar. And over the next 10 to 12 minutes, I will try to give you a snippet of what every woman, every newborn, everywhere, which we call as EWEN, is all about. It's a 10-year-long journey, so I hope if I miss on some of the pieces, I would request Joy to please come in later on and to also add to it. Now, there are two main purposes of this whole partnership, and many of the subsequent speakers who will be speaking afterwards, they have been contributing to this partnership in some way or the another at a country level or a regional level or a global level. And what it tries to aim is, one, align the partner efforts at global, regional, and country level. So move from individual silos to collective action so that we are able to move the needle in the countries. Now, in terms of the even, if you have to say in one line, even turns commitments into actions. And as I said, it brings all the global, regional, and country players together under government leadership towards the 1990-80-80 targets. And I will speak a bit about what they are to accelerate progress. Now, in terms of the unique value of even, there are five major things, but I would just focus on a couple of them. The first is even is largely determined by the member state priorities. It is aligned with what country priorities are, and it does not try to set new priorities for the countries, but only try to connect them with what global happenings are and what the global interventions which are available for them to accelerate progress. The second important thing is the country level support, which involves tracking of the progress to country implementation. Now, a word about what even targets are. So we often say as 90-90-80-80, but what does that mean? It means if you improve the antenatal care coverage of 4 plus ANC to 90%, skill attendance at birth to 90%, the early postnatal care to 80%, and in case there is a complication for the mother and newborn, the availability of small and sick newborn care and the emergency obstetric care to 80%. But when we say 90-90-80-80, we often forget the 65%, which is one of the weak links and is the most important factor to achieve progress, and that is the social determinants and empowering women for informed decision making. Now, even also works very closely with the child survival action. Child survival action is not a competitor of even, it is complementing even. Because if you have been able to save the mother and the newborn, you would also like the newborn to thrive well and to also survive the under 5 period. And the Child Survival Action Partnership has recently finalized their targets. They are yet to be released, but they are around 70% children to be treated for diarrhea, 80% for pneumonia, and 90% for malaria. And then a protective effect of immunization and breastfeeding. So together, if we are able to move the needle on the coverage targets of even and CSA, we should be aligned to meet the SDG targets of both newborn mortality and the under 5 mortality. Now coming back to even, and it's a 10-year plus journey. As I said, in 2014, it was known as ENAP at that time, called as Every Newborn Action Plan, which was endorsed by the World Health Assembly in 2014 in May. And since then, we have been tracking progress of how countries are doing. And our colleagues like Joy, Mary Kinney, and many of them were involved in the early years. And since then, we have now evolved starting from 10 countries in 2014 to now covering 107 countries. And now we track maternal, newborn, and child progress together. The second important role which this even partnership does is bringing countries together at regional level and global level, where we sit with the countries, share with them the current priorities, and help them what is more important in their context and what technical assistance they need. And this was done at the Country Engagement Day at the IMNSC conference on the last day, 2023, where 28 countries came together. And in 2026, a couple of months back, where 36 countries came together. We also did the 3 regional convenings in Southeast Asia, Eastern Southern Africa, and the Western Central Africa. So all in all, we have been able to reach 57 countries through these multiple convenings at global and regional level. And the third thing which is in pipeline for next year is within these 57 countries, identify 8 to 10 high burden countries and have a dedicated country missions with subnational convenings in these countries. Now, I will take a few minutes to share some of the findings about this key progress report, because this report helps us to understand where the key programmatic gaps at the country level are. And this is based on the self-reporting by the country governments. So it's the country government's Ministry of Health who reports on this. And then we analyze this data to come up with some key messages. And as I said, it's a 10-year plus journey. It started as ENAP in 2014. Then in 2022, we brought the mother and the newborn together to make it joint maternal newborn tracking. And this year, we have even got the child together to make it the joint mother, newborn, and child tracking. So this is now a composite tool looking across the life course. Now, just to give an idea of from where this report is coming from, so 90% of the countries from Sub-Saharan Africa and South Asia region have reported. So we are getting the data from nearly all the off-track countries and the countries where the maximum burden of mortality is. Now, in terms of the key findings, one of the important findings is that subnational focus is missing, be it in target setting or be it in planning. If you see on the left side of my screen, nearly 90% plus countries have a national target for maternal and newborn mortality, but only 1 in 4 countries have a subnational target. Same way if you go to the subnational plans, because unless you have subnational plans, you cannot scale up newborn care units at district level. And only half of the countries reported that they have subnational plans. And again, if you look at the 2 regions with the highest burden, situation was much better in Central and South Asia as compared to Sub-Saharan Africa. The second important thing is, though countries may have national RMNCH strategy or MNH strategy, the high impact interventions are underfunded. And one of the things which is very important for all of you is the small and sick newborn care. And only 60% countries have a national strategy for it. And only 29%, like 3 in 10 countries, have a dedicated budget line for small and sick newborn care. But again, Central and South Asia, largely driven by countries like India, Bangladesh, Nepal, Pakistan, have done much better as compared to Sub-Saharan Africa. But again, in Sub-Saharan Africa, we are seeing significant improvement in last 5-6 years. Now, coming to what is the ENAP target for, and I'm focusing more on you because you are all involved with the NEST toolkit, the small and sick newborn scale up. So 80% districts need to have a level 2 newborn care unit. But when you look at the data, only 41% countries have planned for 80% coverage. So what is important is we are setting the target at global level that we need 80% countries to have a level 2 unit at district level. But when you see at planning level, not even half of the countries have planned for 80% coverage, except in South Asia, where 80% of them have planned for a level 2 unit. And if you have not planned for it, having a functional unit becomes even more difficult. And this is what you can see, that only 22% countries in Sub-Saharan Africa said that they have achieved 80% coverage. And these numbers are coming largely from Sierra Leone, Malawi, Tanzania, Rwanda, and a few more countries. While in South Asia, these numbers are driven by India, Bangladesh, Pakistan, and Nepal. Now, coming to another key factor which is important for scale-up of small and sick newborn care, and you can take this message back to your country teams, ensuring equitable distribution of human resources, especially the nurses for newborn care unit, and introducing the provisions for motivation and retention of them, especially in the difficult areas. And this is one area where we have seen more and more countries moving towards it, adapting it. And if you look at some of the incentives which countries have used, which is a mix of financial and non-financial incentives, the financial incentives includes hardship allowances, housing, scholarship, and rare skill bonus. So countries have tried to top up the salaries of the staff of the newborn care unit, the EMOC, by giving these kind of extra allowances in terms of financial incentives. But also important are the non-financial incentives, and countries have gone for things like career opportunities, supportive supervision, and workplace safety. And we had 51 countries who reported on this, and we have tried to analyze what are the top six financial and non financial incentives. Some of these you can take back and advocate in your respective countries. Another important thing for your work is the health information system. Now, if you look at the health information system, in the last tracking in 2022, very few countries were recording the kangaroo mother care, the neonatal resuscitation, the admissions to the newborn care unit, the pre discharge neonatal mortality, the preterm births. But now there is an improvement, though there is a lot still to be done. Like now, 76% countries said that they are recording the admissions to newborn care unit, improvement on kangaroo mother care, but again, still 53% countries have an indicator for kangaroo mother care in their HMIS. Neonatal resuscitation still remains at 62%. So there has been an improvement from the previous tracking after years of stagnation, but still a lot needs to be done in terms of advocacy and action here. And the last key message coming out is families and communities are not at the center of the policies. The basic thing to have a mother or a father in a newborn care unit is still only 62% countries have this policy, though we have improved from 51% in 2022, but still a long way to go. Also, the framework for maternity leave after neonatal death, only half of the countries reported on that. Or involving the parents advocacy group in the MNCH working groups, again, only 1 in 3 countries had it. So, having shown what are the key gaps, we brought together 36 countries on the last day of the IMNSC conference and helped them to identify what their needs for next 2 years are and what is the technical assistance required. And I'm just giving the snippet from the 2 halls. So the first hall was the English-speaking non-conflict countries. There were 13 countries in that hall. And around policies and plans, the support needed was in developing the national strategic plan, but more importantly, subnational targets and plans were countries like Kenya, Liberia, Zambia, and Pakistan. They wanted the focus on subnational targets. In terms of investing, increased domestic financing for MNCH, again, 4 to 5 countries requested around that. And I'm just giving you a snippet of it. For equity, again, the prioritizing the high burden geographies and populations, especially in India, Tanzania, and Liberia. There were a lot of requests around health workforce. And this is an important opportunity for you to push the action on getting the norms and the required health workforce for the small and sick newborn care unit. Many countries are open for looking at the HR planning, deployment, redistribution. And I understand there is a webinar on the health workforce in coming months, and I think it might be good to link this with that. We also tried to look what was different in the Francophone countries. And again, some of the examples from these countries who are there, especially on medical products and commodities, there was a lot of interest in the new products, especially the PPH bundle, caffeine citrate, carbitocin, and also the use of AI for forecasting and other things. And all these priorities then need to go into the country plans. And over the last 2 to 3 years, we have been able to work with a few countries, and I'm just putting some examples, though many more countries are working on it. Kenya, a couple of weeks back, the president of Kenya, Honorable President, launched the Even Acceleration Plan. Same way for Uganda, and same way for Mozambique, which is Chad, which is an integrated plan for maternal, newborn, and child health. So what we are trying as Even Partnership is to convert the thought leadership into a collective action of partners to make actually the difference where it is needed the most. And together we have to be, and there's no option in these times. With this, thanks a lot to all of you.
Thank you so much, Dr. Gupta. I think you have raised some very, very important issues. I must say that as a parent, my heart is very warm to see that we are making progress. We're not stagnant anymore. And I think one of the most powerful things that you said that stood out for me was empowering women to be able to make informed decisions. I think it's so important because in all honesty, the mother is usually the primary caregiver, and a lot of times we have to make decisions on the spot. But if you aren't informed and if you don't know what the effects of those decision making is, we could always land up with different kinds of outcomes. So I love that. I also love that we have 107 countries that are now on board that are sharing data. Data is so important. Like I said in my message, it was one of the things that I was craving to get information on, to know what steps are being made and where the future lays for our small newborn children. So thank you so much. We're going to move on to our second speaker, which is Dr. Pablo Duran. He is the regional advisor in perinatal health, and his background is he is a pediatrician. Dr. Duran, thank you so much for joining us today.
Good morning, good afternoon, and good evening, everyone. It's my pleasure being here with you today, and thank you for inviting us to make this presentation around the challenges and network solutions that we are experiencing and working on in the region of the Americas. The next one, please. So we share globally similar challenges: the high burden of preventable mortality and morbidity among newborns, the challenge of providing support to small and sick newborns and their families are shared by almost all of us. Particularly in the region of the Americas, the inequalities across the life course, the limited access to quality care in several settings, and the gaps in family-centered care are aligned with outdated national plans in several countries. We also share the perspective on priority areas. We know that complications of prematurity, neonatal sepsis, and infections, along with birth defects, rare diseases, are the most challenging problems and situations to respond, but also providing care for small and sick newborn and support for their families, providing care to these babies, but also conditions as development support in some conditions make this a priority. The next one, please. But we also share this main challenge that neonatal health seems to be a low priority at different levels: political, financial, technical. And we know that it's not a lack of evidence. We know that institutional systems create competing urgencies and dominant narratives, prioritize many times other criteria, and many times children are absent and babies from future building discourses. So we see that the strategic response would be, along with the technical response to the problems that I mentioned, is to advocate for a narrative that places newborn surviving, thriving, and transforming at the center of the political, institutional, technical, and social agendas. The next one, please. And how we can address these challenges? We thought that, I mentioned, it's not just about evidence, but through collaborative frameworks transforming the outcomes through evidence-based policies. We need to translate research into actionable guidelines and strengthen health systems. Again, the institutions we perceive and we work on strengthening the response at the institutional level on evidence-based policies. But for that, we need multi-sector coordination among or between agencies, scientific societies, academia, and also the communities toward shared goals, because it's not just a specific responsibility for different sectors, but a common concern, and the response would be multisectorial. And this can be done, and Dr. Gagan mentioned the need for strengthening community empowerment, family participation. So empowerment of vulnerable populations through participatory approaches and resources is absolutely needed. The next one, please. And for that, we have been working since 2008 on what we call the Newborn Health Alliance, which is a multi-sector coordination mechanism to promote newborn health through Latin America and the Caribbean as part of a comprehensive continuum of reproductive, maternal, newborn, and child health through interinstitutional efforts involving United Nations and other multilateral agencies, scientific associations and technical associations, and governments, civil society, and the community. And the idea is to move and provide technical support for evidence-based policies and interventions in newborn health at both the regional level but also at the country and local level that strengthen health systems and empower communities with specific focus on those most vulnerable populations and with specific focus on small and sick newborns. The next one, please. And the other component or the complement of these networks is the family networks. We have been working since the last 7-8 years on identifying and strengthening groups of parents providing and advocating for small and sick newborn. At this time, we could identify, and we are working together in 14 countries with more than 20 groups of parents. The next one, please. And we could learn that they have different and common challenges. Why they were formed? They identify the lack of information from health professionals, the internet search sparking group creations. Some initiated, some have been established by health providers, and the need to educate families and professionals. These have been the reasons, the motivation for establishing these groups. They work in different ways with different aspects regarding membership and structure. Primarily, they are families of small and sick newborns with partnership with university, hospital, or scientific societies, with varying in terms of geographic distribution and work, and they are voluntarily driven fundamentally to sustain their actions. But they perceive that they need to move from virtual to a legal form. The next one, please. So we are working on strengthening the path forward of these networks by strengthening the existing groups, formalizing their structures, and promoting the legal status, securing their sustainable funding, and enhancing their capacity, but also identifying a regional coordination mechanism that contribute on strengthening and coordination their group and supporting new initiatives. The next one, I'm almost finished. And the final network that I would like to highlight is the electronic networks. We have developed this app, which is called eCBB, or eHealth Care for Babies, which aims is to engage in families and healthcare providers in terms of information, education, and communication around small and sick newborn. This is available in the 4 official languages in the region: Spanish, French, English, and Portuguese, and with specific profiles and the different editing and curing content for families or for healthcare providers. The next one, I think it's the last one. So, which is the way forward? A collective vision. We see that neonatal health in America faces significant challenges rooted in systemic inequalities and limited access to quality of care. We work and reinforce the need for political leadership, but also powerful solutions emerge when the networks across scientific, institutional, and community sectors, with the leadership of the political level, are built and work. So family networks for preterm, small, and sick newborn demonstrate the passion, the collaboration, and the access to trusted information that can make transformative changes. So by investing in these networks, we are convinced that we can move closer to ensuring that every newborn in the region survives, thrives, and has the opportunity to reach their full development. The last one, I think, is the final one. So thank you very much, and building stronger networks for newborn health is our aim. Thank you very much.
Thank you so much, Dr. Duran. Oh my gosh. I think you have just reaffirmed, especially to the parent representatives out there, how important our voices are, that we serve a very specific goal, and that is to ensure that we are the bridge between the clinical and between the parents. I love that you said that it's the passion, the collaboration, and the access to trusted information that is going to help all our babies survive and thrive. So thank you so much for highlighting that, how important these networks are, and that investing in them, because I know a lot of parent organizations are definitely run by passion, but in the grand scheme of things, that is not sustainable for a family, for people who are working. So thank you so much for highlighting that. Now we're going to move on to our third speaker. That is Dr. Lalan Bharti, who is the president of the Neonatal Forum in India, leading national efforts in newborn and neonatal health across India. I know India is one of the pioneering countries that is showing us how we can work and build and upscale with sometimes very limited resources. So we are very interested to hear what you have to say, Dr. Bharti. Thank you so much for joining us. You have an extensive background in pediatrics and neonatology, and we are so glad to have you on board with us today.
Thank you so much. Good morning, good evening, and very warm greetings from National Neonatology Forum. It is my privilege to take you through the remarkable journey of 45 years of NNF dedicated to improving newborn survival in India. Today, we will look at the milestones, impact, and the vision ahead for neonatal care. Next slide, please. So to set the context, India accounts for about 25 million births every year. Roughly 1/5 of all global births. Neonatal deaths dominates, under 5 mortality. Initially, child survival effort focused on the older children. Over a few years, the focus has shifted towards neonatal periods. So India has achieved significant progress, reducing neonatal mortality by nearly 70% since 1990, ahead of the global average decline. So that progress is the backdrop for my discussion in next few slides. So next slide, please. So in 1970s, a small group of pediatricians recognized that newborn care had no dedicated voice in India, right? So in 1980, NNF was founded with a clear vision to create standards, build knowledge, and strengthen newborn health practices across India. In the same year, NNF prepared India's first set of recommendations on neonatal care, a landmark that gave us credibility with government and other medical community. Next slide, please. So the 1980s and 90s marked a period of rapid growth. NNF joined the government task force on minimum perinatal care, shaping community-level newborn services. NNF launched neonatal resuscitation program in 1989. By 92, essential newborn care was recommended for inclusion in India's child survival strategy. Through our sustained advocacy, NNF placed newborn health firmly on the India's national health agenda. Next slide, please. So our advocacy reached a high point in 2000 when late Prime Minister Sri Atal Bihari Vajpayee ji launched National Newborn Week on 15th of November 2000. This was the highest level political commitment towards newborn survival and positioning our NNF as a strong voice for neonates. Next slide, please. So our key achievement and contribution. So over 4 decades, NNF has created a lasting impact. NNF pioneered NRP in India and have trained more than 2.5 lakhs healthcare workers in collaboration with other partners, developed India-specific NRP guideline and accreditation standard for NICU, and over 300 units, both in private as well as government, are now accredited. About 3,000 doctors and nurses have received advanced neonatology training through our fellowship programs. We also provided technical support to government for different programs like India Newborn Action Plan, FBNC training, and we expanded internationally too with overseas branches at different countries and strong ties with American Academy of Pediatrics, UNICEF, WHO, Oxford universities, and etc. Next slide, please. So today, NNF represents a strong network of more than 30,000 members through education, accreditation, guidelines, and collaboration. NNF continues to shape the future of newborn care in India and recognized national voice on newborn health policy. Next slide, please. So India has made significant progress in neonatal survival, yet we are far from where we should have been. To achieve our ambitious goal of single-digit neonatal mortality rate by 2030, we need to accelerate our efforts, have a stronger collaboration, and a focused state-specific strategy based on the local need. We need to focus on low-cost, high-impact interventions like perinatal, antenatal care, exclusive breastfeeding, KMC, high KMC. So these interventions can significantly improve survival and quality of life. Next slide, please. So this year, our network continued to grow. On National NRP Day, we conducted over 1,100 workshops on single day and trained around 27,000 healthcare professionals across the country. Through our perinatal synergy initiative, obstetrician, neonatologist, pediatrician, and nurses are working together to ensure a smooth transition from labor room to an ICU and home. And we have been releasing new quick reference guideline every week, covering every chapters from antenatal intervention to golden hour management, KMC, surfactant, ventilation for our resident pediatrician working across the country at different states level. So next slide, please. So this slides highlights the magnitude of the event and our nationwide mission on 10th May 2026, when we trained 26,000 plus healthcare workers in a single day. So next slide, please. So where does this lead? 45 years of dedication, a 70% fall in neonatal mortality rate, and over 13,000 members. The path ahead is clear, and our objective is intact survival. This year, our immediate priorities are at least one trained person at every delivery, scaling digital platforms, joint maternal neonatal training, AI-assisted clinical learning. So our pathway to SDG target and our INAP target rest on 4 pillars: equity, concentrating resources in high NMR states, integrating our quality metrics with national programs like NQAS, Muskan, and digital scale through tele NICU and safe transport to the NICU at home. Next slide, please. So NNF's journey reflects what is possible when science, commitment, passion, and partnership come together. NNF remains committed to ensuring that every newborn, everywhere, receive the best start of life with the mission of ensuring safe, quality, nurturing newborn care for every newborn. So thank you. Please do visit our website, nnf.org, to learn more and join the movement.
Thank you so much, Dr. Bharti. That was some very, very helpful information. It is so important to know that we do have low cost, high impact, effective tools available to help us on the ground. It doesn't have to always be these very expensive equipment that is there. I mean, your parents are your first source of that. So thank you so very much. Guys, please don't forget to use the little chat question box. If you have any questions for any of our panelists, they will answer your questions in the chat. We are now very, very honored to have some people from the Ministry of Health for Uganda. Please help me welcome Dr. Ruth Grace, who will be speaking for the Ugandan National Steering Committee. She is the coordinator and the National Newborn Secretary and comes with a wealth of knowledge in obstetrics and gynecology. Thank you so much, Dr. Ruth.
Thank you very much for everyone who has been able to attend and also organize this webinar. Once again, my name is Dr. Ruth Grace. I'm an obstetrician by training, and I coordinate the National Newborn Secretariat, which is the secretariat that works together with the National Newborn Working Group. In regards to what works to move faster, we did think about sharing with the world the regional newborn networks of care and how we are trying to build this. So for the next slide, please. Okay, thank you. So in regards to our country context, I felt that I should share mainly majority of our MPDSR reports. I assumed that internationally people would know. Currently, Uganda, we stand at an infant mortality rate of 22 per 1,000 live births. Majority of our deaths for the newborns are first stillbirths, followed by early neonatal deaths. And when we look at our country context, again, it does not reduce. And 59% of the newborns that die due to birth asphyxia, followed by septicemia, and then the complications of prematurity, which is a difference in what we had prior. Prior, in the previous years, we've been trying to do a lot of advocacy for the preterms. So then we are having an improvement in the indicators and now having sepsis crop up. When we look at how the structure of the National Newborn Working Group is, when we talk about that, our Newborn Working Group is chaired by the Commissioner, Dr. Mugahi Richard, Commissioner of Reproductive and Child Health at the Ministry of Health. And then under it is governed by the National Working Group. The National Newborn Working Group is supported by the National Newborn Secretariat, which I coordinate. And then under it, we have the Regional Newborn Coordinators. Now, the regional newborn coordinators are pediatricians who are in the different regional referral hospitals. Our context is that the highest level of care in the various regions is the regional referral hospitals. And then below, then we have different health facilities. So we intend that the regional pediatricians will be able to work with the neonatal care unit nurse in charges across the various regions of care. We have about 17 geographical regions. Under every region, we have over 50 facilities, really. So someone would ask, when we talk about the region, what is it that it intends? So it means ideally one newborn coordinator is working with over 50 facilities that are spread across. How have we been able to use different governing approaches to support coordination? We're trying to focus on how do we provide high impact in the high burden areas to ensure that no one is left behind. The picture on the left is showing us the neonatal care unit in the Karamoja region, which is one of the pastoralist areas in the far northeastern part of Uganda. And this is just to show us that here is where we have gone to reach the newborns. We also have one of our neonatologists trained in country who has been able to support the neonatal care units there, improve the clinical care pathways within that region. Now, we also have a supportive environment at policy level, both from the high-level team at the Ministry of Health. We also have supporting political structures that we are trying to see how do we support not only the mother, but also the newborn agenda in every aspect, both at local government, at central government. And through that, we've been able to build accountability platforms that spread across. One, the national platform, and then also the regional platforms. And that region, we're looking at the regional hospital directors working together with our newborn coordinators to see how do we improve perinatal death surveillance and review. How do we improve our networks of care for newborn? How do we improve our referrals to govern and to at least assist that we do not have an overfill of babies in one facility and yet one is unable to admit. Through also, again, alignment of priorities, regional accountabilities. The National Newborn Working Group shares priorities annually where we're able to say what are our 5 priorities that we have for newborn. And these 5 priorities are spread across the different regions and the different healthcare leaders, including our partners, both implementing and development partners, who we work with to ensure that we now have, we can have this disseminated. So if we say our priority is operationalizing neonatal care units as it is this year, we then work together with every other stakeholder to see that we have our units set up and according to level. In regards to policy and decision making, we try to not only centralize it, but also give autonomy to the different regions and different regional coordinators to be able to make the decision, what is it that is happening within my region about newborn care? We understand that, yes, whereas the top 3 causes of death are common across the country, there may be different dynamics in each health facility at lower levels, which will be determined if the newborn coordinator goes there, discusses with the team, and a different unit in charges will say, my challenge for me is HR, my challenge for me is infrastructure. My challenge here is perhaps I have the equipment, but I do not have the knowledge on how to use the current equipment that I have. So we try to make the decision flow that way so that by the time the decision reaches us at the Ministry of Health through the Secretariat, we're able now to see and synthesize how can you implement and how can we support the system to make things work. We've had some wins in regards to the growing the regional networks of care, which I like to call the new nets. So those we gather, we now have what we call the extended newborn working group meeting, which we meet twice a year. This is different from the monthly meetings that we have for accountability in the national working group meetings. And under this, we've tried to see how do we work collaboratively with the biomedical engineers, with the nursing teams, because also as at Ministry of Health, we have a different department for nursing. So how do we get them in? And then they're also looking at how do we work with the biomedical engineers as well. And this is helping us, in addition to pharmacists, it is helping us how? We have now seen an improvement in the knowledge of available existing newborn commodities within the country. Majority of times we find that the clinicians are working within the setting and are unaware that we have products such as support respiratory care, such as surfactant or caffeine citrate. But now through these accountability mechanisms and meetings with the regional newborn coordinators, we're able to preach the gospel and say, hey, people, let's use caffeine citrate for babies. Let us replace our procurements for aminophylline with caffeine citrate for the newborn care units. We're able to push and know that how much of the supplies are available at national level. And through our newborn coordinators, we're able to push through that with the support of the pharmacy teams to ensure that we do proper quantifications and also do redistribution within the different regions. We also are working with the teams to provide building the linkage of the lower level facilities and the Ministry of Health through these units. We have our lower level facilities, but then most of the times we're unable to know what is it that is happening at my health center for what is happening at the lowest units in my country. How do I know that maybe this health center for in a particular region is in need of support for newborn care? So through the different newborn network leaders, we're able to know that and at least provide even room for both advocacy, but then also learning, teaching them, teaching the different various regions to understand that, okay, this is how we take care of the newborn, and then also be able to disseminate the baby, not only being taken care of by midwives, but also a baby who can be able to be taken care of by medical doctors. We work together with the teams, provide regional support, supervision, and clinical mentorships, and also have supported the in-service trainings in newborn care. In Uganda, we did come up with a comprehensive in-service training for newborn care, where we did merge the ENC 1 and 2, but then also added the different components of how do we have leadership within the newborn care unit. And that package, we called it the comprehensive in-service newborn training. And more things that we have birthed, I've talked about this, but then also regional campaigns. And then also we've been able to define our levels of newborn care. If you can go to the next slide. So our levels of newborn care, we acknowledge that not every neonatal care unit is a neonatal intensive care unit. And according to the AWENE targets, we're also shooting high to see that we can have 80% of our districts have at least one level 2 neonatal care unit with CPAP. And I can confidently say that we're on track because we have a supportive leadership. Now, our levels of care, we've defined them as 4 levels of care. And this is based on also our health system structure. If you look at the healthcare facility column on the third area, we look at how is our healthcare system designed. We have health center 3s, which are basic care facilities. And then we have center 4s, which is the first CMOC site for a baby to reach. to reach, which only run by medical officers, led by medical officers. And then we have general hospitals, which right now are the first interaction of a newborn with a pediatrician. And then regional referral hospitals, where we expect to have neonatologists and also pediatricians, and then the specialized hospitals. So the push is to have both the health center force and general hospitals move up to a level 2A and 2B. And our nomenclature for levels of care is as displayed on your screen. So we are maintaining the NICU at level 3, and then neonatal high dependency unit for level 2B, and then special care units for level 2A. This is intended to help us know, one, which baby do I admit at which level, two, which baby can I refer for further care, and then we've been able to put I was saying that in line with this, the guideline for operationalizing neonatal care units, we've already defined our different levels of care. Now, if you look to your left, an example is what was the KMC unit before, but then we transformed it into a special care unit preterm. While we're able to provide the KMC chairs alongside the baby cot to provide for IKMC, immediate KMC, because before the mothers would not be able to take care of the babies. So they were using the KMC chairs as beds. This is one of the facilities. If you look in the middle, it's an example of one of the facilities as well, Mbale General Referral Hospital. We're able to also see now this is a high dependency unit for preterms, using again the low-cost model, baby cots, and then kangaroo with just a monitor and CPAP as well for the babies. Now, when you move to the next slide, we've also been able to create campaigns. It would be absurd if I do not mention this is our month of the Baby's First Cry campaign. Now, we did sit down as a newborn working group and said, we cannot celebrate a baby with birth asphyxia, but we continue to have birth asphyxia as a commonest condition where we have our babies die. So we cannot celebrate asphyxia, we cannot celebrate cerebral palsy, because we understand there's a day for that is hosted under the disability, but we can celebrate a baby's first cry. And this is an intentional advocacy campaign for both health workers and the community to end preventable stillbirth and newborn deaths. Asking the caregiver, asking the mother, did your baby cry? That's the commonest question in the labor suite. It's the commonest question that we also ask when we have a baby who comes in with convulsions. We ask, did the baby cry immediately? But sometimes we just stop at the baby cried. We don't know when the baby cried. So it's important that we push this message out, and we hope that the entire world can adopt it. And if the newborn network as well here can be able to adopt that, we'll be very happy. Have we had some challenges? The answer is yes. The next slide, please. So we still continue to see that there are facilities that have a high burden, and we don't have some bits. We have some bits of lack in infrastructure, but then also in equipment availability, where you find babies stacked on top of each other, like in the upper picture, and in the lower picture you see that there's a different facility that has incubators, but not all incubators are in use. So gaps in critical care, and then also gaps in infrastructure. So this is in different various regions. So we've been able to do a mapping to know that, okay, where is this happening? Because we cannot just buy equipment and then we end up having the equipment not in use. But then we're also having places that actually do not have the equipment and are in dire need. So we've been able to do that. Of course, there are many challenges that come with it when it comes to operationalizing neonatal care units and having the regions work. People are going to tell you we don't have staff. So some places have equipment. They don't have where to put they don't have the staff to actually work with. In some places we've said, okay, fine, give us staff. And then we've given us staff, we say, okay, fine, let's go and train you. Then after we train you, we put you back and you actually moved. I know I'm short of time.
Thank you so much. We are way time. I'm so sorry to speed you along. Thank you for
it's very okay.
valuable information.
I was just concluding. The last slide. The last slide, yes, thank you. For the first time, we're able to light the Ginger Bridge in Uganda as purple, and also say that collaborations make us stronger in newborn, and we cannot do this work alone. Thank you very much.
Thank you so much. That's a big, big one, lighting up the bridge. You made some very valuable points. I actually love that you were able to visually show us that regardless of the space available, that KMC can be implemented, which, as we know, has such wonderful benefits. We're moving on to our last speaker. Please do bear with us for a few more minutes, everybody. I think Dr. John Baptiste Nguranga is one of the leaders. He is the ANA president since August 2025. He brings such valuable information to this discussion, and we just didn't want you guys to miss out on what he has to say. So, Dr. John Baptiste, thank you so much for joining us.
No, thank you, Tasmin. And we don't need to stress you very much, you the organizers, because when things fall a little bit out, you take all the shock, when actually it's us, the presenters, that sometimes stall a few minutes. So thank you for your presentation, and really the Toolkit team and the organizers for the opportunity to talk a little bit more about our new organization, but which is growing in a number of ways. So welcome everybody, those who are joining in to the African Neonatal Association. If we could go to the next slide just to get started. We proceed. That's what we meant to go through. If we could go to the next slide. Yeah. So for the members that do not know much, the African Neonatal Association started just as the video that was played by Tasmin. We never intended before to start an organization. So it started like a professional colleagues WhatsApp group, especially by the group that we had been trained in South Africa. And all of us who trained elsewhere started joining progressively. But as time went on, we realized that there was a need. And look at that. So we started the transitioning to a formal organization in 2020, and it was fully registered here in Rwanda, in Kigali, Rwanda, in 2023. So we do have a broader members and friends across the region, around 305 in more than 42 countries of the African continent. So we are proud as well on how progressively we are steadily growing. Next slide, please. And why are we? Why did we decide to become an organization? Sincerely speaking, we all know the gaps. They have been spoken here, and everybody, I'm sure everybody tuning in comes from, in one or the other, from the newborn space, and that's how you get linked to the toolkit. So we hope that every African newborn can and is possible to receive the best start in life. And to do that, we needed to collaboratively increase and disseminate knowledge, implementation, and best practices that we do. But we are mindful of the challenges across the region and the inequalities that are there. So that is our vision and that's our mission, and we hope we will work towards that progressively. Next slide. Like any other organization, this was meant to talk about leadership, and absolutely leadership is core paramount to what we are thinking about. We have very, very, very audacious strategic plan of 2025-2023. But when you look into 3, we are looking at the key pillars for that, or building blocks, if I may use the word. We talk about how do we strengthen the leadership, the networks at national level, and then cumulatively into the national, regional levels. Again, talking about building the knowledge and the training that we all know that babies are dying because of multifactorial conditions, but one of them is the lack of the appropriate knowledge and skills, and we have had good examples during this webinar. Could we talk about that? Next slide, please, Toby. With that very, very brief history, I really want to go through that. We have grown faster than we thought. We ourselves, when we look back, we realize that what we thought as something to try and see how it works, it's really, really have taken roots over. And one of the success stories that we talk about was the creation in collaboration with Vermont Oxford Neonatal Network, the African Neonatal Network. And that is a collaborative quality improvement, where we started with those countries as a pilot, but the countries have grown progressively. We are very, very appreciative of the Gates Foundation to take it on and support the initiative from the word go. Next slide. The purpose was to create an African neonatal network as simply a learning community. So we wanted to share experience, to learn from each other, to get mentee and mentor each other in that process so that we can learn, we can try to optimize the quality, because we know outside there, as you all know, babies die because they receive inadequate quality of care. So the collaborative QI network through the African Neonatal Network was meant to support each other, learn from each other, so that we can collectively improve the quality of newborn care. Next slide. Yeah, I was talking about growing. So this is through the database that's supported by the Vermont Oxford Neonatal Network. We have more than 30,000 babies now that are cumulatively being managed in the units that are within the African Neonatal Network. And as I said, we started by a couple of hospitals. We are now talking up to 27 units that are spread into about 10 countries. So we are rapidly growing. We feel proud and we are encouraged by the need outside there to be part of the movement. Next slide, please. And we are able to measure impact for just last, because I mentioned formally, we've been able to start doing some pieces of work here and there from the 2021, and we got the seeding grant of 3 years to start the African Neonatal Network, and we can measure the impact. We can see that we are contributing to reduction of neonatal mortality, especially among the more preterm, as would be expected. Next slide, please. Yeah, putting in the numbers, the statistician can manipulate the numbers and they can work. So we doing the statistical metaphors and the way we can do it. We estimate that the improvement in quality improvement in just the participating 27 hospitals, we have saved around 892 lives in the last 3 years of the initial phase of the African Neonatal Network. And we can't be any prouder than that. And we hope to do much more. Next slide. I cannot talk about what we are trying to do without talking about this amazing collaboration that started a little bit early, but officially launched last year. That's the Partnership for Accelerating Neonatal Survival across Africa. Many people that are associated with Toolkit are very familiar with that, but I want to highlight the potential it has when you talk about the data sharing, collaboration, and standardization that we are trying to work out and figure out how we can optimally use data across the collaborating institutions. So we talk about 23 ANN hospitals, 42 member African Neonatal Association members, plus the widespread 137 net 360 facilities. So there is a lot of potential, and we're excited to partner with net 360, really to see how this collaborative QI and data utilization framework and strategy goes. Next slide, please. No, you went a little bit back. Yes. These are just highlights of the amazing party we had for those few who may be on this webinar that joined us in Kigali when we celebrated. It was a bigger party and we had a couple of everybody, clinicians, researchers, funders, policymakers. So it was an amazing evening. Thank you, Joy and the team, for putting up such a world-class show when we launched this amazing collaborative initiative. Next slide. Part of that, as we have done, is that we initiated the Journal of African Neonatology. It's been publishing then. It has an amazing team behind it, the editorial team that has been made it consistent. It is lands in French and English. And that was part of the African Neonatal Association, was to try and break the barriers of language in the region. We know our region is torn apart, different language connotations according to our colonial history, and we hope and we aim and will continue to push and work towards breaking the barrier. So please use or publish your papers at whatever quality to the Journal of African Neonatal Association. It is there to support those. The barrier we needed to break, to be honest with you, was that you are required so much to publish in the so-called high-quality journal, a lot of man and a lot of this. And we need to encourage our colleagues, our members. This is part of our aim to really get people start small, publish whatever small they are able to write it down, and progressively we will build the right to and appropriate the quality of publication that we need. So it's part of capacity building in research and documenting what we do. Next slide, please. We have learned a couple of questions, and you may ask me how many are they, but the truth is we have learned that it is everybody included. It's only you can succeed if you're able to build a team, and a team from the ministry, a team from the stakeholders, partners, the funders, but most importantly, the work done by the clinicians. Because the African Neonatal Association, we needed to see how and which potential we have. We, the clinicians at the bedside, can be able to do if we collaborated and work together. So it takes a team, and a team of everybody, including the cleaner in neonatal unit, to ensure that we control the infection spread in the units. Next slide. And of course, lastly, I think this is my last slide. It's the data with purpose. We have heard a lot about the data, but that remains the truth. No data without a story, and there is no story without data, and that's our metaphor that we move forward. So we want to improve, but we want to document that, and documenting that goes through the data aspect of it. So I'm very happy. The last slide is to say thank you. The last slide, please, is to say thank you, but I'm really, really encouraged to introduce to you to the African Neonatal Association. Please check it out. Please join. Please let us, all of us, the people, the previous speakers, and everybody join hands in this journey. I think we have more potential than we can. Thank you so much for your attention.
Thank you so much, Dr. John Baptiste. That was an amazing presentation. What stood out to me was also no data without a story, and no story without a data, because we need both in order for us to, make the correct decisions and policies. We are so thankful for everyone for staying on with us. Just to let you know that there are some more webinars coming up on the 21st of July. It's the neonatal workforce equation, something that was also mentioned in the discussion. How many, how much, how fast? We need to retain and get more quality skilled clinicians. And then on the 4th of August, a topic close to my heart, World Breastfeeding Week webinar. Please do join up and sign in and watch us. And then last but not least, we just want to thank everybody for joining us. Thank you to all the sponsors, all our panelists, everyone who joined in on the chat, who watched us. We are so grateful, and this doesn't work without having multi-stakeholders. So thank you for your time. Thank you for joining us. Until next time.